At the heart of the American healthcare system lies a surprising contradiction. We've got cutting-edge treatments and skilled professionals, yet millions of low-income families are falling through the cracks. This isn't just happenstance, it's a systemic issue. Take Teresa, a single mom from Mississippi, for example. She was denied preventative care simply because of her Medicaid status. Her story isn't just a sad tale, it's a reflection of a broken system that often leaves the most vulnerable behind. So, let's dig deeper. What's really going on here? Are we oversimplifying the problem by labeling it as systemic discrimination, or are there more complex factors at play? The idea that American healthcare discriminates against the poor isn't new. Since the 1960s, when Medicare and Medicaid emerged during the War on Poverty, voices have highlighted disparities in access and outcomes. But the way these barriers manifest has changed over time. Segregation isn't written into hospital policies anymore, but subtle forms of exclusion still exist. We're talking about insurance denials, clinic redlining, and even implicit bias among healthcare providers. Public hospitals, once safety nets in cities like New York and Chicago, have become less accessible due to chronic underfunding. The Affordable Care Act promised a pathway to better care, but political resistance has created a patchwork system. Some states, like Texas and Florida, have even opted out of Medicaid expansion, leaving millions without adequate coverage. To really understand this issue, we need to look at the broader picture. There are several key players. Low-income families, who are often Latinx, Black, or rural, face significant challenges when it comes to negotiating for better care. Then, there are healthcare providers who have to navigate legal, ethical, and financial constraints. Insurance companies, whether they're Medicaid, Medicare, or private firms, each operate with their own set of motivations. And of course, government policymakers play a crucial role, alongside advocacy groups pushing for reform. Now, the pandemic has really shone a light on some long-standing cracks in the system. By late 2022, uninsured rates among working-age past low-income adults skyrocketed to 22%. Many are forced to skip essential treatments, like insulin or prenatal visits. But there's a silver lining. Telemedicine and expanded Medicaid eligibility in some states are beginning to change the game, providing new avenues for care. So what evidence do we have of discrimination in access to healthcare? Well, it's pretty compelling. A study found that only about half of community health centers in non-expansion states could offer comprehensive adult care, compared to a higher percentage in states that embraced expansion. In Texas, researchers documented widespread exclusion of Medicaid patients by specialists, mainly due to low reimbursement rates. Implicit bias is another factor. A famous study had actors pretend to be patients, and it revealed that Black and low-income patients were less likely to receive referrals for advanced tests, even when they had the same symptoms. Frontline nurses have shared their own experiences, noting how body language can shift when someone presents a Medicaid card. Financial barriers also play a huge role. For low-income families, the true cost of healthcare isn't just about insurance premiums. In rural Georgia, for instance, one mother has to travel hours just to refill her insulin because local pharmacies don't accept her Medicaid plan. Transportation issues are now one of the top reasons cited for missed medical appointments. Then there's the bureaucratic maze that often leads to what's called eligibility churn. Families can lose their coverage due to paperwork issues, and one study found over 40% of children dropped from Medicaid were actually eligible, but fell through the cracks of the system. Experts like Dr. James Perry from UCLA argue that we're not just facing a healthcare gap, we're dealing with a policy gap. He points out that the system has been engineered to benefit the middle class and insurance companies, while others are left behind. Dr. Lila Shah from a major urban hospital admits that financial logic drives hospital behavior. If Medicaid reimbursement rates are low, hospitals will naturally prioritize higher-paying patients. Let's consider some real-world examples. Teresa's struggles with prenatal care in Mississippi illustrate the dire consequences of inadequate access. After losing hours at work, she became eligible for Medicaid, but faced ridiculous wait times for appointments, leading to complications during childbirth that could have been avoided with timely care. On the flip side, in rural Colorado, A telehealth program initially improved diabetes management for low-income residents until the local cable provider dropped subsidized rates, making internet access unaffordable. This kind of discrimination isn't overt, but it highlights how technology gaps can intersect with healthcare access. Some people argue that framing the system as discriminatory oversimplifies the issue. For instance, economist Victor Fuchs suggests that it's not about malice, it's about the economic realities of finite resources. Hospitals often lean toward higher-paying patients simply to stay afloat. Another viewpoint is that individual choices and behaviors also come into play. Distrust in the medical system, sometimes rooted in historical injustices, can deter low-income families from seeking care. Yet, there are positive developments taking shape too. States like California and New York are trying new approaches by integrating social determinants of health into their programs. This means that healthcare providers are incentivized to address issues like housing and nutrition, not just medical needs. Some early results are promising. As we look ahead, it's clear that many stakeholders recognize the current state of affairs isn't sustainable. But without a unified political voice that connects the interests of low-income families to the broader middle class, the entrenched issues of discrimination, whether through neglect, financial logic, or bureaucratic inertia, are likely to persist. In conclusion, the price of care for low-income Americans isn't just about dollars and cents. It's about life years, social mobility, and missed opportunities. Simplifying the conversation to solely blame discrimination misses the bigger picture, where profit motives and systemic issues intersect in often tragic ways. The stories from rural Georgia to inner-city Baltimore highlight not just the suffering, but also the resilience of those affected. The real challenge isn't just identifying discrimination, it's addressing the deeper structural issues that allow it to flourish. Until we confront these challenges head-on, the cost of care will remain unacceptably high for those who can least afford it.